What we're going to talk about this morning is the benefits from thrombolytic therapy in the management mostly of venous disease, but also in the management of arterial disease. And the risks associated with it, because in the ICU, this is what mainly you're going to be doing. You're going to be watching closely these patients to prevent untoward complications that can occur between the minute you looked at the patient and the minute you went back to your desk to sit down thinking that everything is okay. Things can happen just in a matter of a second, and that is why extreme diligence is necessary to continue watching that patient closely. Now, why do we do this? What are the benefits of thrombolytic therapy? In the venous system, the main risk factors of patients having deep venous thrombosis are multifactorial. A lot of them have to do with age, the presence of cancer, obesity, just being in the hospital. Think of it this way, about 40% of the patients who spend time in the hospital and go home develop blood clots. Most of them unrecognized. Most of them, over the course of weeks down the road, may develop pulmonary emboli that they didn't even know they had. And they go to the clinic, get treated for a pneumonia or a chest infection or bronchitis. The last 3 patients we treated with pulmonary emboli were misdiagnosed as pneumonia and bronchitis and were on antibiotics for a week or 2 until the amount of clots overwhelmed their lungs to the point of near death. So this is a serious problem. Now, obviously, patients who are immobile, like all these patients who come in from nursing homes who've been in bed for a long time, I would assume that they already have a blood clot. Anybody coming from a nursing home who hardly gets up and walks around, they have a DVT. Take that for granted and assume that it is. So therefore, continuation of the pharmacologic prophylaxis, Lovenox, sub-Q heparin, is so important. And a high index of suspicion, such as that you would say, okay, maybe this patient's been in bed for a month coming in from a nursing home. We should do a baseline venous duplex scan, and don't be surprised if there is a blood clot. In younger women, we see a lot of DVT secondary to hormones, contraceptives, the pill. Pregnancy, because of the gravid uterus putting pressure, compressing the vena cava, reducing venous return, creates a lot of what we call stasis, which is sluggishness in the flow of blood clearing out of the leg. Coagulation disorders. The most commonly inherited disorder is the factor V Leiden mutation. Okay? In people of Mediterranean background, southern France, Italy, Middle East, and all that, about 30% of these people have a factor V mutation. Think of it this way. There's a lot of pooling these days. America is a melting pot. There's a lot of people who have Italian backgrounds. You have other backgrounds. Think of that when you're looking at the patient and saying, could this patient be a factor V carrier? Serious illnesses. All these patients who are in the ICU, in bed for a long period of time. There are a lot of cytokines that cause myocardial depression. They cause significant stasis, and these patients have significant risks. So think of it, this list, and then you'd say, most of your patients have at least 1, if not 2 of these listed here. Now, what happens really in surgery, and where does the clot start? In surgery, the clot starts during the operation, after the induction of anesthesia. Most of the clots form at the cusps of the valves, and all of us have valves in our veins. And these valves are distant about, say, 5 inches between your ankle and your groin. Between your groin and your heart, there are no valves. So there are no valves in the iliac veins, no valves in the vena cava. The first valve is at the groin, and we call it the terminal valve at the level of the saphenofemoral junction between the saphenous vein and the femoral vein. There are valves in the deep system too, and superficial system. And most of the cause of varicosities is due to incompetence in the valves. So when you're standing up, bearing down, or coughing, or if you're a little overweight, these valves leak and blood falls down. And when it falls down, there's a significant stasis. Normally the blood flows in the venous system like the wind. Unlike the arteries, it's a pulsatile propulsive wave. In the veins, the blood flows, goes up, comes down, goes up, comes down, and then over the course of time goes up again. As a result, all this twirling creates a lot of blood sitting there at the cusp of the valves. And that's where these clots will end up forming, with clumping of red blood cells and so forth. The actual function of the calf muscles is so important in squeezing and pumping and emptying the veins out of the legs. That's why we tell patients, pump your calf muscles. That's why we tell patients that the benefit of the compression stockings will help in squeezing the calf muscles and emptying the blood out of the veins in the leg. And the actual compression of the calf by these supportive stockings does aid as well in activating the fibrinolytic system, your own system. Your body does produce that medicine that we give to the patients to bust the clots. Okay? So, literally speaking, Virchow's triad in the pathophysiology of blood clots has to do with endothelial injury. How so? Well, let's say we put a central line in the patient. The main actual of putting a needle in that vein, passing a wire, putting a catheter in there, that is an insult to the vein. The vein and the body is going to interpret that as an insult. A clot will start developing there. And believe me, all these dialysis catheters that we put in the groin will develop a DVT. Will, not maybe, will. That site will develop a blood clot. This patient is laying in bed, stasis of blood coming out of there, a lot of them with hemodynamic instabilities, low blood pressure, so forth. That site is going to get a blood clot. And you have to be super diligent in monitoring that. That's why we don't like to have these femoral lines stay in for long. And if we have to have them, but try not to have these for long. Hypercoagulability, obviously, all these inflammatory states that the patient is in with infection and so forth can create a hypercoagulable state as a result. Now, what is the goal of therapy? This is the abbreviated portion because we have about a half hour, but the goal of therapy is actually several things. To preserve the valve is number one, because these clots will damage the valves. Preservation of the valve prevents development of what we call the post-thrombotic syndrome. The post-thrombotic syndrome, swelling of the leg, discoloration of the skin. You've all seen these legs with leathery skin. The patient feels like blood's crawling on it. They're scratching it all the time. They get stasis dermatitis. Many a times mistaken for cellulitis, but it is stasis dermatitis. What we want to do is we want to prevent this, what we call lipodermatosclerosis. We want to preserve the valve. We want to prevent chronic venous hypertension, which is high pressure in the veins. Most veins in the legs have a normal pressure of 0 to 5 millimeters of mercury. If I sampled any of you here, that pressure is low. But in venous hypertension, to get an ulcer, you have a pressure of 60. Think of it this way. If you put a needle in that vein, you'll feel like you're in an artery. The blood will pulsate. You'll stick the patient for a venous access. You'll say, oh my God, did I get into the artery? That blood is pulsating just because of venous hypertension. Restoration of flow and limb salvage in phlegmasia cerulea dolens, which is the ultimate worst condition that can happen to a leg, is the bluish discoloration from ischemia. If all the veins clearing that leg are clotted, that leg is at risk of dying. That's an emergency from a vascular standpoint. And obviously, in patients who have pulmonary emboli, we want to improve hemodynamics, particularly in patients who have right ventricular strain, and that's what we look for in some patients with massive PEs or submassive PEs. We do an urgent echo, look at the right ventricular pressure, look at the effacement of the right ventricle, and intervene to salvage the patient from the standpoint of prevention of equalization of pressure, because that's what ends up killing the patient. Okay, so again, we talked about that, PEs to prevent this, caval thrombosis, patients with IVC filter thrombosis and inferior vena cava thrombosis. We have one patient in the ICU now, yesterday we worked on, clotted off from his vena cava all the way down. Everything was clotted. Iliofemoral DVT from the iliac veins down. Any DVT proximal to the sacrofermoral junction, meaning the fossa ovalis. The fossa ovalis is right here. That's where the femoral and the saphenous join. Any clot above the sacrofermoral junction in the iliac or in more proximal common femoral is at risk of causing limb ischemia, particularly in the venous system. Now, what is the history behind it? Our first case here in 1993, we started dripping. We did not have the fancy multi-side hole catheters. As a matter of fact, my first case was a effort thrombosis of the subclavian vein. Young man comes in, construction worker, put an IV in the dorsum of his hand. We ran urokinase. Okay, still around, as I think it's Carolyn McKinnon's brother. And basically, after we lysed his subclavian vein, we went in and took out his first rib to prevent a recurrence of this problem. But we call that effort thrombosis. But the technology has evolved since just simply putting an IV on the dorsum of the hand or at the ankle as we started in 93. Now we have multiple side hole catheters, which we started using in 94, 95. And from there, that took a while. Took 2-3 days, if any of you remember these long-standing thrombolytics without doing anything mechanical, just simply dripping. So what we did was we put in a catheter with multiple holes in it, and we dripped slowly over the course of hours. And that medicine converted a solid clot back into a liquid. So the blood started circulating again once the clots were dissolved. Since then, we moved on to a mechanical system, the angiojet. And the hospital had a little function there at the Life Center, so they raised money, and we got the angiojet machine, first generation. Now we have a third generation angiojet machine. And what the angiojet does, it pulses saline and occasionally a combination of saline and some TPA to bust the clot and then sucks it as it morselizes it. And that cut down somewhat the length of treatment. Then we invested in a company called that had the ECHOS catheter. And the ECHOS catheter is a catheter with multiple side holes, but inside the catheter there's an ultrasound wire. And that ultrasound wire creates at different frequencies vibrations that help in breaking down the clot, and not only that, better mix of the medicine into the clot. So the clot itself is getting, different parts of it is getting kind of bathed by the clot. As a result, we end up with better distribution of the medicine into the clot and better results with clot busting. And the last and most recent system we invested in is called the trellis system, which has cut down significantly on the treatment. And some of the patients that receive the trellis you may not see in the ICU, because if I do standalone trellis, I bust them and I suck the catheter with the catheter, the clots, and then basically they may not make it to the ICU as a result. But this is the current technology. So there's potential dripping. So you may see a catheter with a multi-side hole just dripping the medicine. One where the angiojet you're not going to see up there because we've already treated the patient, but the side effects of the angiojet you have to be looking for. And what happens when the angiojet, there's that mechanical busting. So there's a jet that hits the red blood cells. Some of these red blood cells fracture. And when they fracture, they release hemoglobin. And hemoglobin is a protein that ends up being excreted in the urine. But what happens is that it is toxic to the tubules of the kidneys and can cause renal failure. So what we do when we see that rosaceous color in the urine caused by the mechanical action of the angiojet device, we initiate a mannitol drip to promote an osmotic diuresis. So mannitol pushes the urine out. It's almost like a liquid Drano, flushes the kidneys, okay? And then we initiate a bicarb drip, and usually 3 amps in a liter of sterile water, and we run it at about 80 to 100 an hour. The purpose behind it is to alkalinize the urine. When you alkalinize the urine, you reduce the risk of that hemoglobin molecule from depositing on the tubules and causing acute tubular necrosis. So the two strategies when the angiojet has been used to prevent that ATN would be to alkalinize the urine, and if we start seeing that the urine is turning bloody and it almost like rosé wine, which is a wine between white and red, you start the mannitol drip. Now you will not see that same thing happen with the trellis. That happens only with the angiojet system. That does not happen with the echoes. So echoes, just regular drip with the unifuse catheter, or trellis does not cause this actual hemolysis. And then if you draw blood after you've done the angiojet, forget it, the lab's going to go crazy. They'll say, what's going on with these results? I can't tell. There's hemolysis, so don't draw blood. Wait till several hours later to check your coags, to check your electrolytes, because all these results you may not believe, and they are going to be irregular and erratic. So now that we've gone through the different systems that we have here, the overall advantages of the mechanical devices, obviously, in reducing the overall duration of the lytic therapy. Initially, when we just dripped without mechanical devices, we ran the drip for 2 to 3 days sometimes. But now, with these mechanical devices, we significantly have reduced the thrombolytic delivery to about 48 hours, to 24 hours, 8 hours to 24 hours. Now, the May-Turner syndrome is a syndrome which is more common than initially thought. May-Turner is not the name of a doctor, it's the name of a patient. Now, in general, the anatomy normally is that the aorta, at its bifurcation, the right common iliac artery sits on top of the left common iliac vein. And right in that location, right there, that artery is elbowing the vein. So literally speaking, squishing it down. And in those patients with the May-Turner syndrome, the clot starts here and propagates down. Okay? So when you see a patient with May-Turner syndrome, most of their clots start higher up just because of that extrinsic compression that the artery is shutting down the vein by just simply squishing it down. And I see that mostly in women, but I see it in men as well. And a lot of those have been instigated by other factors, like I saw it recently in a male who had hip surgery. Why did he wait till he was 65, 70 years old to have a DVT and then turned out to have a May-Turner syndrome? Things happen. So the iliofemoral DVT progresses from the stenosis and goes down distally. So this is an example. This is one of our local pictures. We have already a filter in place. And this is the, after busting the clots, there's some residual chronic here. This is all chronic, not acute clot. And you see the narrowing in that vein. So then when I put the stent, you see how narrowed the vein is? You could see how that stent is squished here by actually the May-Turner. And then what I do is I balloon it, and then the vein is more open. This is an example of a patient 10 days after hip surgery. And when you do surgery, there are limitations to how much clot busting medicine you can use because of bleeding. Over the course of years and experience, I've been narrowing down, so I'm safe using some clot busting 7 days after surgery and beyond. But in people who have, this was earlier in our experience, I did not want to use any clot busting medicine in this patient. And this patient had a vena cava filter that was clotted. So the vena cava down, and his leg, you see how much more swollen that leg was compared to this one. And you see in those patients who have proximal DVT in the iliofemoral system, the clots are higher up. Therefore, you will feel for the thigh, and that thigh will be big. It will be edematous, and the swelling is all the way up to the groin. Now this is the trellis system, and the trellis system has a catheter that oscillates. And when you do these oscillations, that catheter is going to oscillate and it's going to be morselizing the clot. So there's a balloon proximally and there's a balloon distally. And that catheter is going to sit there and oscillate, and what is like having a clot in a blender and you're blending it. You're morselizing it. So what I do is I morselize it with this system, and then I put a big garden hose 9 French guide catheter. Now for those of you familiar with these, the sheath for the Swan is an 8 French. So this is a 9 French guide catheter. And I use one of these vacuum syringes and I suck out the clots. And the clots come out in globs. The white clot is an old clot. The red and dark clot is a fresh clot. And then what you do is you recover these clots, and these clots, after you've been morselized, you remove them. And you see this is a white clot, this is a chronic clot, and you see that this clot, TPA will not really do much work on it because it has too much old fibrin in it. The fresher clots, TPA will do some work on it. So this is an example of old, fresh. And this is after the swelling, after the treatment. So this is 16 hours post-therapy. Significant reduction in the swelling of the leg. Now, phlegmasia ceruleus albans is a condition where the leg and the foot is white. Phlegmasia ceruleus dolens, the leg will be blue at that time. Okay? So the albans, dolens. Dolens is associated with a lot of pain. Mortality, we've had 0. Amputation, we've had 0. All because of these techniques. Okay? Now, most of these patients, if they were not treated with thrombolytics, a year afterwards will end up with a leathery leg, so swollen that when they walk, they hurt. So that is a significant cause of disability. Therefore, we have to treat these veins. This is an example of phlegmasia ceruleus dolens. And you see the swelling and you see the bluish discoloration. This is post-therapy. And you can tell the leg that was treated because I always like to put ACE wraps. The reason why I put the ACE wrap is to prevent bleeding from the 9 French sheath that I put behind the knee. But you don't want to put an ACE wrap behind the knee and leave the foot because the foot will swell up. So you got to start with the ACE wrap from the toes up. But the leg that was treated looks a little less swollen than the leg that was not treated. And this is an example how we retrieve these thrombus. Now in pulmonary embolism, we use similar tactics. We put a catheter, we guide the catheter into the clot, and we drip the medicine. And we could use either the ECOS system or the Unifuse. The difference between the ECOS and Unifuse, as I recall, is putting in a wire that has a vibrating ultrasound inside the catheter. And we drip TPA. With the ECOS system, you will see that my doses of TPA are lower than with the Unifuse. Because of that mechanical vibration of the catheter, we are able to achieve the same results with a slightly lower dose, hence reducing the potential risks of bleeding. Now, TPA in the recombinant form has a half-life of 15 minutes. So you stop the TPA, the drug is out of your system completely, usually at 2 half-lives. So you stop the TPA, the drug is completely out of your system by 30 minutes. Your own TPA has a half-life of 5 minutes, your own body's TPA. So recombinant TPA is genetically engineered TPA, and its job is to bust clots. However, once it circulates systemically, after some of the clots that we have worked on have been busted, you can bleed from a venipuncture. You can bleed from an ABG site. You can bleed from a catheter site. My worst nightmare is when the patient is unstable and somebody in the ER puts in an ephemeral arterial line, and then I bring the patient up to do a thrombolytic on. I said, we never want to put an A line in a patient you're going to do TPA on. You don't want to do that. You don't want to put deep sticks in the patient at the same time. Now, usually when I do these interventions, whatever sheath I inserted, whatever catheter I inserted, I leave it in during that treatment. Like if I did a jugular access, but at the same time, if I'm busting from below and I have a jugular catheter, I watch very closely for a hematoma in the neck from forming, because you don't have much room in the neck. A small hematoma can compromise the airway, just like that. A small hematoma will cause the patient discomfort upon swallowing. And the first symptom that you have to be very, very diligent in listening to the patient is if they tell you, I'm having a hard time swallowing, then that hematoma is big enough to cause them problems. You sound the alarm, saying this guy can't swallow well, he's got a bruise in his neck. Somebody has to immediately take action. I would stop the TPA, I would evaluate, I would make sure that the fibrinogen is not low, because what TPA does, it breaks down the clot. And your fibrinogen level, it drops below let's say 150, your risk of bleeding spontaneously, even without TPA on board, is significant. So one would transfuse with cryoprecipitate if that fibrinogen level is very low. And I usually have a parameter. I use a safe margin, usually say, call me if it's less than 200. It doesn't mean that if it's going to be 175, the patient is at risk. But at least I know that that fibrinogen level is on a downhill slope. When the fibrinogen level is on a downhill slope, it means some of the medicine is going systemic. Because when I infuse the TPA, I want that TPA to be bathing the clot, not bathing the rest of the body. I want it inside the clot. Now, but when that clot busts and the channel is open, that medicine is going to find its way into the rest of the body. And that's when the risks of bleeding increase significantly. All right? So when we've achieved the goal of clot busting, that's when the medicine will go drip somewhere else, and the site where the phlebotomist drew the blood from 2 or 3 days ago will start to form a hematoma. But then if a hematoma forms, we don't stare at it. We have to compress it. We don't put warm compressors or cold compressors on it. We sit on it. We put an ACE wrap. We directly compress the site for several minutes. Then we put an ACE wrap and we watch it to prevent a compartment syndrome from developing. And if the hematoma and the compartment is compromised, we then discontinue the thrombolytic therapy. And we evaluate what the fibrinogen is. And we transfuse the cryo if the fibrinogen is low. Now mind you, if the fibrinogen drops and you stop the TPA, the fibrinogen will have a chance to come up on its own, but that will take a little time. Therefore, if it is very low, we should transfuse with the cryoprecipitate. So this is the catheter that has multiple side holes. And as the patient is laying in bed, that medicine is basically dripping through all these side holes. And like the patient that I did the other day had a 50 centimeter side hole. So about 50 centimeters of catheter had multiple side holes on it. And that medicine was dripping, and we were treating at multiple levels. This is the echoes. This is an example of a caval thrombosis, vena cava, full of clots. This is after we've busted it open. Little residual here, chronic, but pretty much nicely open. And this is the white stuff that I tell you about, a lot of chronic white stuff. And this is the clot, and this is pre and post. And this is the thrombus. Look at some of these long chronic that I get with the 9 French guide catheter. This is another caval thrombosis case. The blood, this is one iliac, the other iliac, nothing in the cava. This is the clots that we get out of it. And this is post-trellis. And then I dripped some more with the echoes. So this is an echoes catheter from here to here. Each one of these is a centimeter apart, and each one of these is an ultrasound, will emit the ultrasound waves. So you'll drip some TPA after that. And this is after the echoes. We've improved it somewhat even further. And in general, some of the drawbacks of the angiojet we talked about, but making sure that we alkalinize the urine, and I usually may start alkalinizing the urine if I do the angiojet with greater than 100 ml exchange. And you force the diuresis. Now let me get on to and show you a couple of pictures here. Okay, this is an example of the shot on this patient in the ICU. This is a shot from above, from the jugular. I put his, and look at all the clots, and his cava is completely clotted. See that? The filter has no flow whatsoever through it. Completely clotted. And then I did a shot from his leg. See, all this is clots. There's no flow in there. The whole system is clotted. And this is a power shot. So the blood's going nowhere, and it's all clots. All these lucencies there are clots, and this is from the knee down. So when I put in my catheter, I put my needle and my wire and my catheter inside the clot. I don't expect blood return. So what I did on this patient, his is his old filter. I put a temporary filter above the old filter because his initial presentation was he was having atrial arrhythmias. And that's one thing I forgot to mention to you, is that when the patient has atrial arrhythmias, like AFib, SVT, acute right bundle, all of these are suggestive of pulmonary emboli. So we clinically diagnosed this patient. I said to the team, this guy's got, his cava is clotted and he's flipping emboli. That's why he's having all these atrial arrhythmias. They had him on a diltiazem drip. I moved him from the progressive care to the ICU. And then we set him up for the thrombolytic. So indeed, that's why we put in a temporary filter, which I will remove tomorrow. So tomorrow I'll go in and remove the temporary filter since we opened the other filter. Now yesterday, I put echoes on him, and this is after we did his thrombolytics. And you see how we got his system reopened. Then we did a shot into the cava. And here's the cava. There is flow beyond it. This is the new filter. This is the old filter. There is some chronic stuff left here, which I worked on. by use the catheter to extract some of these thrombus, and add my catheter up there into the cava, and you see how the flow is brisk going through that area. Then we did a last injection, and this is the final result, is that the entire cava is open here. There is some chronic residual material here, but a good portion of the lumen is open. And that is not going to go anywhere because it's chronic adherent material. And this is the temporary filter, which I will be removing tomorrow. So then we got his system reopened from his, what before was clotted is gotten reopened there. All right. Any questions in reference to the, again, diligence is very important from the standpoint of watching for bleeding. Don't feel the sense of assurance that everything is swollen now, nothing is swollen now. That hematoma can form within minutes. That's the frustrating part. You think you're doing a superb job, and then you'll see my frustration on the other end. Here we go again. The drain came out this morning, or the hematoma formed, or something like that. You know, I know you're keeping a close eye on things, but just remember, with that medicine on board, once that medicine goes systemic, these clots can form very, very fast. Okay? Any questions? I'm sure you have some. Okay, thank you for your time.